Good evening to everyone. We're honored very much tonight to have Dr. Mark L. Braunstein to join us. After work in academic medicine, Dr. Braunstein founded a series of health informatics companies in 2007. He joined the faculty of the Georgia Institute of Technology, where he developed the first two public health informatics massive open online courses or MOOCs and a three-course Health Informatics Professional Certificate on edX. In 2018 and 2019, he developed a similar course at the University of Queensland as a visiting scientist at the Australian eHealth Research Centre, the Health Informatics Laboratory within CICERO, the Australian National Research Organisation. He returned to Australia as a visiting scientist in 2022 and 2023 and has also been working with AEHRC and UQ on an innovative informatics-based approach to case-based learning in medical education. He is a frequent speaker at academic and industry meetings. The second edition of his textbook, Health Informatics on FHIR, How HL7's API is Transforming Healthcare, was published by Springer in 2022. I hope we can get a link later on. And it's the first book devoted to the current and future impact of FHIR on healthcare in the US and worldwide. Dr. Mark, we are very happy to have you. We've formed a network of interoperability labs in AHIN in 11 countries, and I think your contribution tonight is going to spur us forward. Go ahead, Dr. Mark. The floor is yours. Thank you.
Thank you for the introduction, and I'm very pleased to be able to speak to your group tonight. The talk is generally non-technical. I intend for it to be understandable by anyone in the audience, no matter what their background or interests. And I'll be happy to answer questions when it's over. So, what do these interesting new technologies, FHIR and SMART, do? Well, the simplest way of thinking about it is to relate it to something that we're all intimately familiar with, because we use smartphones all the time for various things, and we just take it for granted that we can install apps on our smartphones, give them permission to access our location, our contacts, or whatever, and they'll do useful things for us. Well, the simplest way to think about SMART and FHIR is that they do the same thing for electronic health record systems. Properly implemented, it's been possible for FHIR apps to be installed in electronic health record systems, just as smartphone apps are installed on your phone, access the data they need with permission, and do useful things for physicians, for patients, and for others in the healthcare ecosystem. And most of this talk is going to be about some of the interesting things that people have done with this burgeoning new technology. First, what does it really take to be successful with digital health? And these are what I feel are the key success factors. You obviously need access to healthcare data in a reasonably predictable form. You have to be able to develop tools that integrate into the workflow and process of their intended users, and that to the maximum degree possible, obviate the need for duplicate data entry. This is particularly important with physicians who tend to be very busy and who won't, it's been demonstrated over many decades, won't tolerate digital tools, won't utilize digital tools that don't fit well into their workflow and process and that require duplicate data entry. Having accomplished that, those are sort of the platform success factors. We need to use them to appropriately provide clinical decision support. Physicians have also told us over many decades that if we overwhelm them with alerts, with things that might be wrong or that they might need to pay attention to, and that a high percentage of the time those alerts are really not relevant in the particular patient or the particular clinical circumstance they're dealing with, then physicians will just ignore all the alerts. Finally, and this is something that I think probably interests many people in the audience, we want to be able to enter data once and use it for many purposes. So it's entered for caring for a patient. We'd like to be able to use it for other things like population health, public health, or clinical research. So these are the key things to try to accomplish. Well, FHIR, which I'm going to explain in very basic terms, and I don't even claim to be going into all of the various nuances of the FHIR standard. But FHIR creates a predictable data model. It's instantiated in something called resources, hence the R in FHIR. And they're structured around the things that, the objects that we manipulate in caring for patients, such as patients themselves. What is the data we typically need about patients? Obviously, their name and their demographic information. Providers, clinical observations, so the things that physicians observe or that are brought to the care of patients by ordering laboratory tests or other kinds of studies. Conditions, the problems that patients have, medications, the things that we prescribe for patients to take. And those are just 5 of the resources. When the entire standard is fully developed, it's estimated there'll be 150 of them, not all of which are involved in direct patient care. Some are involved in things like workflow and process management or clinical reasoning. Now, in the United States, there are a number of important governmental initiatives that have led to the widespread, increasingly widespread adoption of FHIR and the use of FHIR-based tools. One of them is US CDI, the US Core Data for Interoperability Standard. And all I'm trying to show here is that it's mapped now, as you see on the bottom, to FHIR resources. So in the US, we said that FHIR and its resources are the modules, the elements that will be part of our core definition of data for clinical interoperability. Now, the second technology that I'm going to very briefly discuss is SMART. This was developed by Boston Children's Hospital. It's actually developed before FHIR came along, but in a completely different form that didn't succeed. And the people at Boston Children's were wise enough to recognize the importance of FHIR and to switch their work to FHIR. Now the standard is quite widespread. So it does basically 2 things, or 3 things. It uses the OpenID Connect common web technology to establish the identity of a user. And it uses another common web standard, OAuth 2, to establish the data elements that a particular person or app are allowed to access. Properly implemented apps built on the SMART and the FHIR technology platform can be so well integrated into EMR, as I'm illustrating here, that they appear to be part of the EMR. This is a app from a company called DoseMeRx, actually in Brisbane, here in Australia. And it's that large white area, which is within the Cerner power chart. That white area is the same area that physicians use to record data and access data that's in the patient's chart. So the app operates in that same area, appears to be part of the chart, if you will, although the user interface is likely to be optimize the purpose of the app. The app, oops, this thing is very sensitive. The app is accessed, as you see here, from the same menu that the physician uses to do the other things that they do. And as I said, it operates in the same area of the screen where the other parts of the EMR operate. I've highlighted the area here. So it appears to be part of the EMR, which makes it an integrated part of the physician's workflow and process. And down here, I mentioned that the third thing, the app with permission can go fetch the data that it needs to operate from the EMR automatically. So frequently when smart FHIR apps are launched, they're pre-populated with the information they need, and they give the physician, these are used by people other than physicians, but I'm just gonna, it's easier just to talk about physicians. Give them the results with no data entry at all, or minimal data entry at all on the part of the physician. So you can see that the combination of these two technologies solves two of the critical success factors that I mentioned earlier: a predictable data model and integrating tools into workflow and process. A third element of the FHIR technology, again, actually put forward by the Boston Children's Hospital Group, is CDS hooks. This is a standard that allows clinical logic to be embedded in the EMR and to drive the provision of appropriate clinical decision support. Clinical decision support that is relevant, or certainly appears to be relevant, to the specific patient that's being cared for at this specific point in time in their care. And this is an example of that from a company called Remedy. I'm an advisor to the company and on their board, actually, so I'm a little bit prejudiced toward them, but they do a lot of things that illustrate some of my points. So here, the Remedy app, which I'll explain in more detail later, is bringing in continuous glucose monitoring data from a device that the patient's using at home, and is providing the physician with clinical insights based on the last 2 weeks of the data. And when it seems appropriate, uses CDS hooks to present the physician with what's called a card. It's a white, in this case, a white overlay on top of what the physician's looking at. And here, the top card is an example of a clinical decision support rule that's invoked because of data from the continuous glucose monitoring device. And here's one that's invoked by an accepted guideline for the care of diabetes. So in both cases, the clinical decision support is provided in real time at the appropriate point of care, driven by the situation with the patient, the patient's data, and the rules that are embedded in the clinical decision support logic. We also talked about recording data once and using it for other things. And Remedy is also a good example of that, because they provide not just tools for individual patient management, but tools for managing patients at a population level. And they actually provide clinical decision support at a population level. Here, this particular screen displays for the case manager who's using it, the specific devices each patient has in their home, and presents alerts based on data from the device or guideline deviations. I got those backwards. So guideline deviations or device data. Well, this has led to some very interesting things that are pretty far advanced in the United States, and I think are going to be coming around the world. The major EHR vendors in the United States now all operate FHIR app galleries. And based on each vendor's prescribed methodology, the developers of apps can apply and have the app hosted in that vendor's app gallery. So this is the Cerner app gallery. Anybody asks me why I'm only using Cerner for examples, well, I would certainly love to use Epic as well, but they don't like people using or showing screenshots of their products and systems and tools. So I use Cerner. And here are 3 examples of what I think are particularly interesting apps in the Cerner app gallery. I think they're all also in the Epic app gallery and several other major app galleries. And we're going to look at each of them one at a time. But first, what are the clinical challenges? Before I talk about the challenges to digital tools overall, what are the challenges we have to overcome to get practitioners, providers to use these tools? And we're then going to see how these FHIR apps are designed to help overcome those. First is efficient data entry. If you survey physicians in the United States, where almost all physicians now have an electronic health record, you'll find that the most common objection is that it takes too much time to chart. And that's consistent, right? Among physicians who like their EMR and physicians who don't like their EMR. It takes too much time to chart. Secondly, we need to have intuitive retrieval and review of each patient's data. Far too often, EMRs just mimic the paper forms and tools that they replaced. That's not a very creative use of an interactive technology like computing. You'd think we can do better. Third, we need to have meaningful record sharing among providers and patients. And fourth, we need to be able to retrieve data, not just at the individual patient level, but at the population level for purposes like public health, research, and so on and so forth. So these are challenges that people are trying to overcome with FHIR apps. The first one is Suki, which is focused completely on efficient data entry and retrieval. Suki is an AI-based dictation assistant. So we all use Siri, or we use Google Assistant, or Amazon's Alexa. Well, Siri is the same thing for medical charting. I earlier made a point about how FHIR apps can be installed embedded in EMRs. They can also be standalone, separate from an EMR, typically so they can run on a tool like a smartphone. And Suki is an example of that. Still using the same FHIR data model and the same smart tools, but running independently of the EMR. So here, the physician says, Suki, create a clinical note, and a note gets generated to their preferences. Insert my normal review of systems, change, but I want to alter things a bit, change respiratory to cough and shortness of breath. So the physician dictates using this digital tool. Suki also offers what I believe is intuitive data retrieval. Here, the physician simply says, Suki, show me Mrs. Ramirez's medications, and there they are. Physician notices that 2 of them are diabetes medications. So we're assuming here that this is not a patient the physician is familiar with. And so the physician says, show me a graph of the hemoglobin A1C over time. And there it is. So using the same AI technologies that we all use every day, physicians using Suki are charting and retrieving data from their patient charts. Well, does it work? Well, in the United States, the American Academy of Family Physicians, the largest physician group in the United States, is a strong proponent of digital technologies. And they even created an innovation lab where they incubate digital tools. Suki was one of their early successes, and they did a study and found that 60% of the physicians who were offered a chance to try Suki adopted it fully in their practice. And those physicians reported a 72% reduction in their average documentation time. That's a stunning result. And this resulted in savings of 3.3 hours per week per clinician. And the physicians reported improved satisfaction with their workload and overall with their practice. Pretty amazing stuff. Juxley is another startup FHIR-based company that has developed a FHIR app called Timeline. And as you can see here, it pulls in the entire patient chart. This isn't like Suki, where the physician asks for what they want. Here, it brings in the entire patient chart, presents it in a timeline view. The physician can scroll backward and forward in time. They can drill down to get more detail. They can filter, just like we're all used to filtering using other digital tools. So I only want encounters that were mine, all types, inpatient, outpatient, emergency. I only want medications that I prescribe, and I only want them to be active. And the physician will then see the filtered subset of data based on those criteria. They can also, as shown on the right, get the information presented in a grid flowchart format. So a radical new way of looking at patient charts. I said that I would describe a bit more about Remedy. So it's a comprehensive platform for metabolic disease, cardiometabolic disease management, diabetes, heart failure, fatty liver disease, cardiovascular disease, obesity. They've just added asthma. And it does a context-specific summary of the chart. So if the physician using the drop-down there says, well, I'd like to focus on the patient's diabetes, Remedy creates a display of the information that's most relevant to the patient's diabetes. And as you see on the right here, calculate scores to show the degree of control of the patient for this particular condition. Physician can also, as shown here, get a more summarized view of all the patient's chronic diseases. As we all know, patients with chronic diseases tend to have more than one. And then they can drill down from here to the level of detail they want. Remedy has tools for the patient as well as for the physician. So patients record data using an app, using devices in the home, like a glucometer in this case. So here on the left, they've recorded, their glucometers recorded blood glucose data. On the right, the patient has recorded their dose of insulin each day. Remedy brings all that together along with the data that's in the EMR and provides the physician with insights that they may want to pursue further. It also has an integrated messaging function, so the physician and the patient can communicate with each other through their respective FHIR apps. In Atlanta, where Georgia Tech is located, Emory University's medical school has not only adopted FHIR, but has become a center for FHIR app development. And I'm going to show you quite an interesting tool they developed for the management of deep brain stimulation, which is a complex procedure that involves sending electrical impulses to specific parts of the brain to control things like tremors, to help with addiction, management of epilepsy, and so on and so forth. Well, deep brain stimulation requires an orchestrated series of events that need to happen at the right time in the right way. The patient is responsible for a lot of them, so that the patient has an app that is customized to their plan of care, helps them manage appointments, has a checklist of things they're supposed to do, allows them to see their journey, what they've done and what they're going to do in the future. And it has an app, and that of course is a standalone app running on a smartphone on the left. On the right, the physician has an EMR embedded app that allows them to keep track of how their patients are doing, make sure that they have done the things they need to do before a scheduled visit or conference, and actually will reschedule things if they haven't done them. So this is a pure workflow and process management tool. There's no clinical decision support. There's no great use of data from the EMR to manage a complicated clinical workflow and process. I also said that it's important to provide sharing of data among providers and their patients. Now, in the United States, and we'll talk a bit about the federal government initiatives that have led to this, electronic medical record systems are required to offer patients a FHIR gateway from which they can download their record as FHIR resources. And the first major organization to take advantage of this was Apple. So anyone with an iPhone, at least a current or a recent iPhone, I guess, in the United States, has the ability to download their medical record from any one of over 10,000 hospitals and healthcare organizations onto their phone, where their medical record data, along with any health-related data, such as activity data that the phone may have collected, are available to app developers. So developers can develop apps, go through Apple's certification process, and offer those to patients as well. So here on the very left is an actual screen where a patient can see a record of a vaccine immunization that they've had. This is actually real data. A friend of mine doesn't mind, or gave it to me. I'm happy to have it made public. Down at the bottom here, I'm not quite sure why Apple provides this, but the patient can click on FHIR source data and actually see the resource that was downloaded from their medical record, and that drives the display that they're seeing here. Recently, tools to do the same thing have appeared for the Android world. One of the leading companies in that regard is OneUp Health. This is a display of data from a real patient's medical record pulled down into their Android device. But this symbol here is Health Connect. Google and Samsung recently released a toolkit to basically do the same thing that Apple's doing. So we're going to have, at least in the United States, pretty ubiquitous ability of patients to get their medical record data onto their phone, no matter whether it's an Android phone or an iOS phone, and to use digital FHIR app tools to manipulate that data. So FHIR has now become a global phenomenon. I've been talking about the US, which for reasons we'll get into a bit later, is probably ahead of most, if not all other countries in terms of the adoption of this technology. But this is a diagram of traffic to the public FHIR server, one of the probably the busiest public FHIR server. So traffic data is a good marker for FHIR activity around the world, and you can see that it's pretty ubiquitous. The very dark area around India almost certainly relates to the enormous amount of software development taking place there, and it is not indicative of the amount of use of FHIR for clinical purposes. Although, as you'll see, India is going to be using FHIR. So there are a number of nationwide efforts to promote digital health that have FHIR at their core. The first is, I can't pronounce it, Satu Sahat. The folks from Indonesia, I hope I didn't butcher that too badly, which is a ambitious national effort to create a digital health interoperability platform that encompasses patients, healthcare facilities, the government, and the health industry, all based around FHIR. And I assume that is CSIRO's Onto server as the terminology server in that effort. India's national digital health blueprint calls for both patients and providers to have FHIR apps that allow patients to download data from the FHIR app, which is a basic EMR. And the hope is that the patients, particularly those in rural areas, will have their health data with them when it's needed. Those of you familiar with India know that it's a vast country, and travel is a difficult undertaking. Currently, as illustrated by this poster here, both government and private projects are underway to begin to further develop this vision. And the EU has a project called Interoperate, which also entails both provider and patient apps, FHIR apps. The use case there is a bit different. They're concerned about cross-country care. Obviously, as you know, the EU is a lot of countries, 32, I think, in a relatively confined geographic area. So it's predictable that patients may need healthcare in countries other than their home country. And so that's one of the use cases that this is being designed for. Another one is contributing data to medical research. Getting back to the United States, though, FHIR apps aren't just being connected to EMR data. The US, which, as you know, doesn't have universal health care in general, does have it for people who are over the age of 65. And the program is called Medicare, not to be confused with the Australian Medicare program, which is a universal healthcare program. And Medicare doesn't actually deliver healthcare, it just pays for it. So when US citizens, such as me, I'm old enough to be covered by Medicare, goes to the doctor or hospital or gets healthcare in any other venue, a claim gets submitted to the Medicare program, which then pays for that care. So Medicare doesn't know a lot clinically. If I have a lab test ordered, Medicare knows that it was ordered, but it doesn't know what the results were. However, unlike almost any single EMR system, Medicare knows everything about my care because it's paying for everything. So the interesting things you can do with that, and this is one of my favorite examples and Medicare has launched its own smart FHIR app platform, and there are a number of apps on it. The one that I find most interesting is Kidney Choices. So in the three-step process, it asks patients to answer a few simple questions to determine whether they're at risk for developing chronic kidney disease. If it determines that they are, it offers them the opportunity to connect to the My Medicare site to gain access to their Medicare claims data. And if they do that, it looks at that data to see if they've had all of the screening work done that they should do because they're at risk for chronic kidney disease. And in this case, it said you haven't had any of the recommended lab tests and says, would you like to send a note to your physician? And they can do that. So this is very interesting if you think about it. It's really empowering patients through access to their data to be more proactively involved in their own care. One of the things that we said earlier is a objective of digital health, or should be. The last thing we talked about was access to data at a broad level, or a population level, for population health, for public health, for research. And another new component of FHIR is bulk data access, also put forward by the Boston Children's Hospital Group. And here I'm just showing you a sample app that's posted on their website to illustrate what it can do. And there's a small database of make-believe patients behind this. And here I've said I'd like to get the patient and immunization resources for all the patients covered by a particular insurance plan. And when I run that, the data gets downloaded in a special format called MD-JSON, which is, as I've done here, easily converted into an Excel format. And from there, it's easily graphed. So I did this. This is something I actually did. It took less than 10 minutes, and I ended up with a vaccine distribution graph for a population of patients, which could have been my clinic or could have been a much broader set of patients. So an illustration of the latest additions to the FHIR toolkit for accessing large quantities of data. So how did so much of this stuff happen in the United States? And because of the fact that this is a multinational group, I think it's important to recognize that governmental action is critical. It happened because the US government decided to make it happen. And this is President Obama in late 2016, or it might have been in January 2007, but very late in his second term, signing the 21st Century Cures Act, an act that was designed to give patients access to their health data digitally so they could contribute it for research. And over time, as the FHIR standard evolved to the first normative version, the US government, as everybody knew they would, has mandated that access that patients should have to their data must be via a FHIR gateway. That's why all the EMRs in the United States now offer a FHIR gateway. The government says they have to. This act also created the US Core for Interoperability. So a defined subset of all the clinical data in the world that we want to be represented in a standard FHIR way so that it can be shared. And over time, that will evolve and get richer. And it also outlawed data blocking. In the US, we had a problem that health systems compete with each other. So they weren't all that interested in sharing data with their competitors. They wanted to make it easy for patients who got all of their care within their health system, easier to do that because they had installed an enterprise system within their organization. And as long as the patient stayed within their organization, it was easy to get to their data. Now, the law says, well, you can't do that. You have to make that data available no matter where the patient goes. Another governmental action that has taken place to promote even broader sharing of data is TEFCA, the Trusted Exchange Framework and Common Agreement. So on the right there, I've listed the major regional health information exchanges in the United States. TEFCA defines a framework, a contractual and infrastructural framework, leveraging FHIR and the US CDI, the core data set, to provide a way that these health information exchanges can exchange data with each other, can store data and share data in a common framework toward a goal of nationwide data sharing. So that's what's happening. What might this lead to in the future? Well, first, a very interesting study in the United Kingdom done for the National Health Service and chaired by Dr. Eric Topol. Most of you may be familiar with that name, but he's a very distinguished academic who's very involved in leading edge technologies, genomics, digital medicine, so on and so forth. And the study, unsurprisingly, concluded that these new technologies, genomics, digital medicine, AI, robotics, will change the roles and functions of healthcare providers over the next 2 decades. And on the right is by the way, there's a link to the study if you want to read it. It's very well written, very well worth reading, I think. Sort of forecasting how impactful the various technologies will be over time. And you'll notice that some, like the genome, are already having a significant impact. Others, like predictive analytics, they feel will have an impact further out. And they were asked to look at what the impact on the workforce of the National Service might be. And they looked at specific technologies, in this case, patient apps. They forecast that if only half of the patients with COPD used a particular app, that the National Health Service would save 84,000 bed days and the equivalent of 150 full-time nurses. It's one app. Use of speech recognition, that's Siri, we talked about earlier. Might save the equivalent of 230 physicians. That's inpatient, acute and emergency physicians, and 600 outpatient physicians, and 3,200, 600 hospital physicians and 3,200 GPs. AI, the use of artificial intelligence to read imaging studies, would save the equivalent of 500 radiologists. So these are significant potential savings. This study was done in 2019. And here's 2 sentences from the conclusion. As digital technologies become more prevalent, there's a risk that a deluge of automatically transmitted data will overwhelm healthcare professionals. The application of AI to generate patient summaries may provide a clinically useful solution to this problem. Use of AI to automatically generate patient summaries. So that's 2019. Well, in 2022, a group from Cordell Tech, an interesting new technology institute on Roosevelt Island in the East River of New York City, formed a company called Abstractive Health to use AI to create patient summaries. So this organization is not yet a year old, and they were kind enough to provide me some information so I could give you a sense of where we're going. Now, before I do that, I want to say that this isn't just a situation that is brought about when a lot of data is brought in by digital technologies. For example, they're focused on discharge summaries. When a patient leaves the hospital, or when the patient leaves an emergency department to go into the hospital, physicians write a summary of what took place. That's time consuming. Could a computer do it for them? Well, the initial evaluation of the tool that they developed on the right, you see the yellow box, is that 62% of the automated summaries that their tool currently produces, and it's still a new tool, has yet to be tried in clinical practice, but they're going to start piloting it in the emergency department at New York Presbyterian in the spring. But already it met, in the judgment of physicians, their quality standard 62% of the time. And here is an example. One of these is a summary, a discharge summary of a patient being sent home from the hospital, written by a physician. And the other one is written by Abstractive Health's software. Can you tell which one wrote which? I've tried. It's not easy. When an expert panel of physicians was asked to judge these two summaries, the one on the left, which is the one written by the computer, on 4 criteria: quality of the writing, readability, factual correctness, and completeness, got a score of 8 out of possible 10 points. The one on the right, written by a physician, did a little bit better, got 8.75 out of 10. So by all appearances, we're heading toward, but we're not very far away actually, from the use of AI-based tools to begin to do time-consuming tasks that currently physicians do. So how does this work? Well, I wanted to show you this because this uses the trendy new tools that we're all talking about. It doesn't use GPT, the language model, the generative language model behind Chat GPT, but there are others. A lot of people don't realize there are others, and it uses Facebook's BART, which is another generative language model specifically designed to summarize text. And in fact, the use case that Facebook had in mind was summarizing the news. So if you go to a news summary on Facebook, the odds are it was actually generated not by a human. In fact, I think it's almost certainly the case it was not generated by a human, it was generated by BART. Since so their goal here was to do summaries, so logically they're using a generative language model designed to do summaries. Interestingly enough, this model was trained on news from CNN and I think it's the London Daily Mail. Another tool in their toolkit is something called constrained beam search, which I can only tell you, and this is apparently not easy to do, although it sounds easy to do. It informs the model that certain words must be in the output of the summary that it produces. And finally, it uses a tool by Google called BERT, which stands behind all the Google tools that we all use: Translate, Search, Assistant, and more. But of great importance to our talk, it's based on getting the data from the EMR into this pipeline to generate the summary, and all of that's done using FHIR, so that this tool can be installed on major EMRs, starting with Epic in their pilot this spring. So that concludes the talk. As they were kind enough to say in my introduction, I do have a new book. It's now a year old. Time flies, and most of what I've said to you here today comes from the book. Although some of it, like the generative language model stuff I just said, was not on my radar screen when I wrote the book. And as far as I know, nobody was trying to do it against DMRs using FHIR at that time. So thank you all very much. I'll be happy to answer any questions.
Thank you, Dr. Mark. Wonderful presentation. We usually allocate 1 hour, but I think we have to make an exception because there are many questions in the chat box now. Let me triage that. If I lose connection, that means I'm in the tunnel right now. There's a good question here. I really like it. And it's a theoretical question of if you are a CEO, okay, if you were a CEO of a pharmacy chain of 10,000 stores, all operated by a single software under your direct control, how would you start implementing FHIR? Which disruptive innovation seems possible? So you're in control. There's 10,000 of them. How would you do this, Dr. Mark? Go ahead.
In 10,000 pharmacies?
Yes, 10,000 pharmacies or a chain of stores. You have 10,000 of them. How would you start implementing FHIR? What's the strategy? Over.
Well, an interesting question. Not something I've actually given much thought to. But if it were pharmacies that presumably are computerized and therefore have pharmacy records for the people that use that pharmacy, I would begin to think about what sort of digital tools I could provide to the patients using my pharmacy to help them understand the medications they're taking, how to use them, help them comply, help them recognize when they may be having side effects or interactions among and between those medications, and giving them a way to report on those things back to my pharmacist so we can have a closed loop and reach out to those patients when we need to. The pharmacy I use in New York has an app that I can use to refill a prescription. And they have a computer where my records are stored, but they haven't made the connection that I just suggested, that they could greatly enhance the quality of their clinical services through a FHIR app that they provide to their patients. And that would be what I would do.
Thank you, Dr. Mark. For those who are interested,
wait a minute, I will say one other thing.
Sure.
Now that I thought about it another moment, keep in mind that those patients can also download their medical record now, in the United States at least. And I would certainly think about what additional clinical safeguards and services I could offer the patients if my app had access to their medical record. For example, I might be able to spot side effects or problems of medication interactions that the physicians actually noted without recognizing that it was related to one or more of the medications the patient's taking. That happens a lot.
Thank you, Dr. Mark. I think, as a clinician, but also as an advocate of patient empowerment, there's a balance between how much we're willing to expose of our prescriptions, but of course they have a right to that kind of data. Another question, for those who are interested in Dr. Mark's book, there's a link in the chat box. For those that are sharing links from blueprints from other countries, thank you very much.
Oh, I see a question here. Are there any implementations of FHIR integration with patient-generated data from wearable smartwatches with EHR? Well, that's what Remedy does. That I showed you that. Now, they bring together actually data from EMR and data from smartwatches and other devices, and give the physician an integrated view.
How do you marry the device ID to the remedy? Is there a process for? I mean, it's a patient that will do that, right? That says, this is my device and I'm linking it to my.
Well, yeah. Well, the company, so the company markets this platform to health systems, and the company supports a number of integrations with a number of devices, and that are commonly used. And the health system actually typically decides what devices they're going to recommend that the patients use at home to provide this integrated view. I don't think Remedy is currently gathering data from the iWatch or the Google Watch, the smart watches. I could be wrong, but I don't think they are. But I know that people are starting to do that sort of thing as well.
Question for Mayang again. Can FHIR address the issue of polypharmacy? For example, someone walks into my pharmacy asking for DSR. I guess that's another drug. But they mostly actually need just rabeprazole. It's like, how do you know whether one drug is actually what the patient needs? Is that a FHIR thing or a more a terminology thing? Over.
Well, I mean, FHIR is just a platform. You have to write software apps to actually provide this sort of advice and service that's being implied here. The issue, at least in the United States, is that patients, particularly patients with lots of medical problems, are seen by lots of different doctors, in part because we have a real shortage of primary care physicians in the U.S. They complain about the same problem to multiple doctors, and they end up on multiple prescriptions, often for the same medication or for medications that are effectively the same, and patients get in trouble. I mean, I actually have had friends who've gotten very sick, or in one case nearly died because they were on many more medications they should have been, and the medications shouldn't have been taken together. So FHIR certainly gives you a way of getting the data in a reasonably standard form. Typically, the patient who's seeing multiple doctors and getting all these prescriptions is getting them all filled in the same pharmacy. That's typically the case because patients typically use whatever pharmacy is most convenient to their home or maybe their place of work. So that's why the first question that I answered is really actually an important one. The pharmacy is in a position to be proactive, to provide the tool to take a holistic view of the patient's medications, along with their, if you think about it, their medical problems, but you can get those now since the patient can download their record and identify where patients are having issues that relate to polypharmacy, overprescription, interactions, that sort of thing, which is a huge problem. I mean, at least in the U.S., misuse of medications and problems that relate to those misuse are a major cause of hospitalizations and even death. and almost all of that is nobody's looking at the big picture. And I should say that, as you said in the introduction, I started out in academic medicine. Most of my work then was on early pharmacy management systems. So you're really asking for something that I've had a long-standing interest in, and a lot of what I tried to do way back then and hoped could be done is now practical because of the facile sharing of data that FHIR allows.
The last question was about pharmacies, and why would a pharmacy implement FHIR if it's just one of the institutions that are related? And I think you answered this question, just making the data available to the patients. And then there's a question from Dr. Binji
Well,
from the
I mean, if I'm envisioning that the pharmacy would develop a FHIR app which the patient can install on their iPhone or their Android phone, take advantage of the access to the other clinical data that the patient can get on the phone, and to do that, you have to do it in FHIR. And that's because that's become the platform. If you don't care about being able to access anything else, then I suppose it doesn't have to be a FHIR app. It can just be a native iOS app or Android app.
Thanks, Dr. Mark. A quick question from Dr. Binji is the security aspects around FHIR. Can you say something about the security of the FHIR framework or the FHIR servers over?
Well, that's really outside of the standard. The SMART tries to deal with the identity and access permission issues, and does that using the same technologies that we use all around the internet for similar purposes elsewhere. So, you know, the ability to keep unauthorized people from getting into a system where health data is stored and getting to that data is not something that FHIR is going to hinder, but it's not something that FHIR in of itself is going to help with either.
And a question about how much would a single physician license of Remedy cost, iPhone or Android, which is more easygoing?
I don't know.
Okay. I think just
if
a link.
If someone wants to email me, my email address was on the last slide. I will refer them to the company. I have no idea.
Got that. Thanks, Dr. Mark. I think we covered the questions. Most of them are from Mayank and also about pharmacy, which you covered.
I assume they were from Mayank. Yes.
Yes. Okay, so I think we covered most of the questions, and we thank you, Dr. Mark, for your one last question from Hung Nguyen. What about over decentralization of EMRs? Even in one province, how did the advocacy go in Australia or US to make it the standard or common among platforms?
I'm sorry, I'm having trouble understanding the question.
I think it's how did the US do it? How did the US tell the hospitals that they should use FHIR? Is it just by mandate, or did they offer carrots or sticks over?
Well, so before all this, the U.S. had a program with carrot and sticks to get hospitals and physicians to implement electronic medical record systems in the first place. I mean, in 2008 and 9, when a couple of studies were done and published in the New England Journal of Medicine, less than 5% of physicians in the U.S. had an electronic medical record, and I think it was less than 2% of hospitals did. So the government basically said, implement a certified electronic medical record. We have some criteria by which they're certified. The criteria were not all that tough, and meet certain other criteria we've laid out for how you use the electronic medical record, and we'll pay for it. Actually, we'll give you an amount of money that turned out to be more than it would cost if you knew what you were doing. So it was a generous incentive. The stick was, if you don't do it, you're going to suffer reduced payments from Medicare in the future. And then the government began to implement programs to move the U.S. healthcare system away from pay for procedure. You're probably all aware in the United States that the more a doctor does, the more a hospital does, the more money they make. So there's actually a disincentive to be careful about spending money. So there's a serious effort on the part of the federal government and the private insurance companies in the United States now to offer an alternative payment system where there's a financial incentive for the hospital or the physician to deliver high quality care cost effectively. Doing that involves collecting and reporting data that it's almost impossible to do if you don't have an electronic medical record system. So a lot of factors in the US have pushed people toward getting a system. Then a law was passed. I discussed it with you, 21st Century Cures Act, which said that electronic medical record systems had to provide patients with a digital gateway from which they could download their records. The assumption was once the FHIR standard was sufficiently mature, the government would say, and that gateway has to use FHIR. So everybody started working on a FHIR gateway even before they were required to, because everybody knew that's where it was going to go. And indeed, if I remember correctly, it was early 2019, 18. I can't remember which. Maybe it was 18. At a HIMSS meeting, the government announced that it would have to be FHIR. So the U.S. is where it is because the government took actions to get us there. And the reason I emphasize that is I think most of you live in countries where to really get where we want to go, your government's going to have to do things.
Yes. And that's why our members are mostly from the government, so that they can hear these stories coming from the other countries as well. And this is very important for them to know that, there are countries that are actually adopting a standard such as this. Thank you, Dr. Mark. There are no more questions. If there are more questions, because we've gone over time, I think we'd like to thank Dr. Mark. And I will compile other comments from the people who will be contacting us. Usually after the talk, they send us more questions and requests for more topics, Dr. Mark. If you don't mind, we'll send them to you, and maybe we can program another one for another topic.
You would do me a great favor. This is a different audience than I'm used to talking to.
Yes.
I would really appreciate feedback as to whether this talk met your needs.
We will get the feedback. That's a standard process that we have for every webinar. We will do it, Dr. Mark. Thank you.
Thank you all.
So thank you, everyone. Good night, Dr. Mark, and good morning, good afternoon, good night for everyone. Thank you, Dr. Mark.
Thank
Bye-bye.
you, everyone.